Liver. Liver trauma. Liver injuries are commonly associated with affection of other intra or extra-abdominal organs, commonly ribs, pleura, lungs, colon, and spleen. The prognosis after treatment depends on associated injuries. The liver is the second common solid abdominal organ to be injured. It's preceded only by the spleen. Both account for 75% of all blunt abdominal injuries. In bullet injury, the damage is directly proportionate to its velocity, so the most harmful are the high-velocity missiles of the rifles. Etiology. Accidental trauma is that either blunt, as in road traffic accidents, penetrating, as with stabs and bullets. Iatrogenic is increasing with the rising popularity of invasive investigations, as percutaneous liver biopsy and PTC. Spontaneous rupture of the liver is an extremely rare that may happen with eclampsia or hepatic tumors. Pathology. Type of injury. Small subcapsular hematoma, small superficial tear or tears, large subcapsular or intrahepatic hematoma, large deep tear or tears, shattered liver parenchyma, which may include a whole loop. Vascular injury. The most difficult to control is that of the main hepatic veins because of the difficult access. Consequences. Bleeding. This is the main danger. Should be the main concern of the surgeon. Most liver injuries stop bleeding by the time of expiration, but some of them cause death from blood loss. Hematobilia. Liver hematoma sometimes communicates with the torn bile duct, blood to trickle down the biliary passages to the GIT. Liver injuries draw attention to their presence because of intraperitoneal hemorrhage. Stabs in the chest, as high as the fourth intercostal space, can transfix the diaphragm and injure the liver and/or the spleen. Clinical picture. History of trauma. Abdominal pain, abdominal tenderness and rigidity due to parietal peritoneal irritation, either by blood or escaping GIT secretions. Massive bleeding presents with the picture of hemorrhagic shock. Investigations. Chest X-ray. The presence of lower rib fractures suspects liver affection. Diagnostic peritoneal lavage, DPL, ultrasound or CT scan are done in suspected cases to discover minor bleeding. These tests are particularly useful in the unconscious patient as it's difficult to assess the abdomen. Laparotomy. Systemic exploration for penetrating abdominal trauma. Treatment. Management of polytraumatized patient, ATLAS. Hemodynamically stable patients with no evidence of peritonitis. Treated conservatively by repeated examination. CT scan may be repeatedly performed. Hemodynamically unstable patients have peritonitis or deteriorate under conservative treatment, need laparotomy. Principles of surgical management. Adequate exposure by longitudinal incision that can extend to the chest in case of need. Thorough systematic exploration of the abdomen to assess liver affection and to detect other intra-abdominal injuries. Priority is for arrest bleeding. Most small liver tears stop bleeding by the time of the abdomen is explored, so no treatment is required. Liver hemorrhage can be controlled by a combination of temporarily packing the bleeding area and application of Pringle's maneuver, which is application of a vascular clamp to the free border of the lesser omentum or holding it between the two fingers to occlude hepatic artery, portal vein for a period for 20 minutes. The lessened rate of bleeding allows the surgeon to visualize and ligate the injured vessels. Dealing with different types of injury, suturing liver tears whenever possible should be avoided because it's likely to leave space for accumulation of hematoma which may infect or communicate with intrahepatic bile ducts. However, it's restored to it if controlling of bleeding is not possible in the deep layers, tying sutures over pedicled omentum. Deep transverse matrix sutures using special liver needle. A hematoma is explored to ligate the damaged vessels and ducts to excise the dead tissues then left open for drainage. A loop that is shattered beyond salvage, excision of this loop. Firm packing of inaccessible and difficult bleeding areas, such as hepatic veins, may be the only method for temporary arrest of bleeding. The patient is transferred to specialized center where the pack is removed in the operating theater and deal with the injury. Multiple intraperitoneal drains are placed to guard against collection of bile and blood. Prophylactic antibiotics are prescribed. Prognosis. Mortality rate is from 15 to 20%. It gets worse if other major organs are injured. Suspect liver injury in patients with fractures in right lower lips. Minor liver injuries can be treated conservatively. Pringle's maneuver is useful for temporarily controlling hepatic bleeding during the operation. Perihepatic packing is very useful as a last resort to stop bleeding in serious hepatic injuries. Infections of the liver. Pyogenic liver abscess. This is a serious, highly fatal disease. The key to improving results of its treatment is by early diagnosis. Etiology. Sources of infection. Biliary tract, portal vein, arterial system, and idiopathic. Idiopathic, the source of infection is not possible to trace. Arterial system, hematogenous abscess. The source can be bacterial endocarditis, tonsillitis, IV drug, or osteomyelitis. Staphylococcus aureus is the usual causative organism. Portal vein, suppurative appendicitis, or colon diverticuli may induce septic thrombophlebitis of the portal vein radicals, leading to portal pyemia and multiple liver abscesses. Streptococci and anaerobes are the common organisms. Biliary or cholangitic abscess. This is the commonest of all sources, ascending cholangitis caused by the bile duct obstruction, resulting in multiple abscesses of the liver. The likely organism is E. coli or other gram-negative bacilli. Infections of the liver, viral hepatitis, pyogenic liver abscess, amoebic hepatitis and abscess, hydatid disease of the liver, hepatic schistosomiasis. Today, fewer patients present with portal pyemia, probably because of early diagnosis of intraperitoneal sepsis and the widespread use of potent antibiotics. Predisposing factors for the pyogenic liver abscess are immunocompromised patient, diabetes mellitus, leukemia, chronic illness, old age, alcoholics, transplanted patients receiving immunosuppressive therapy, an already existing liver lesion as hydatid cyst, amoebic abscess, or hematoma, rarely, complications, direct extension to the pleura, lung, pericardium, or peritoneum. Clinical picture, symptoms and signs, symptoms, fever and its constitutional manifestations, toxemia with right hypochondrial or lower chest pain, signs, abdominal examination, tender hepatomegaly, however, may be absent and the patient just presents with PUO. Features of the causative lesion are evident, such as Charcot's triad of the cholangitis or the pain of acute appendicitis. Investigations, lab, leukocytosis, anemia, high ESR, low serum albumin, high alkaline phosphatase and transaminases level, elevated serum bilirubin in cholangitis or multiple abscesses. Imaging, ultrasound or CT scan to diagnose and localize the abscess. Treatment, broad-spectrum antibiotics are prescribed. As for any abscess, the treatment is drainage of pus. Now, depend on percutaneous guided drainage of the pus. The procedure is simple, done under local anesthesia where ultrasound or CT is used to direct the needle towards the abscess cavity. The abscess is aspirated, then a tube drain, pigtail is inserted. This procedure has replaced the standard method of open or laparoscopic surgical drainage. Amoebic hepatitis and abscess. Incidence of amoebic hepatitis commoner than pyogenic abscesses in developing countries, particularly those lying in tropical and subtropical regions. The low standards of hygiene, coupled with high humidity, favor amoebiasis infestation. Etiology: due to infection with protozoal parasite Entamoeba histolytica, the condition is a complication of amoebic colitis. Pathology: gross picture, the trophozoites invade portal blood from the colon and migrate up to reside in the liver. The right lobe, especially the posterior superior segment, which is the commonest site of the liver, is affected more than the left. This is explained by observation that portal blood from the right side of the colon drains mainly to the right lobe of the liver, while that from the left colon drains to the left lobe. As amoebic colitis affects mainly the right colon, it's expected that amoebic hepatitis affects mainly the right side. The parasite starts a process of liquefactive necrosis when there is heavy infection. The necrosis results in formation of an abscess, which is usually single and unilocular. Pus is usually sterile, with brown chocolate color and sometimes pinkish, likened to anchovy sauce. The abscess has a shaggy wall that harbors the amoeba. Differential diagnosis: pyogenic liver abscess, hepatocellular carcinoma. In Black Africans, assume rapidly progressive course with pain and constitutional symptoms that simulate those of an amoebic abscess. Complications: secondary bacterial infection, rupture into pleura, lung, pericardium, or peritoneum. When the abscess ruptures upwards, lung abscess rather than empyema, because two layers of the pleura are obliterated. Clinical picture: symptoms: upper abdominal pain, low-grade fever, in contrast to the high-grade fever seen in pyogenic abscess, anorexia, nausea, and weight loss, clear history of an attack of dysentery, not always obtained. Signs: the patient is pale, looking toxic, ersy look, tender hepatomegaly, there may be tenderness in the right intercostal spaces, chest examination, right basal lung abscess or right pleural effusion. Investigations: lab, positive stool analysis and serological tests are useful in diagnosis in non-endemic areas. In countries where amoebic colitis is prevalent, these tests are likely to be positive in high percentage of the population. Blood picture: this is commonly leukocytosis and anemia. Therapeutic test: the high success of metronidazole treatment and improvement in the general and local conditions after 3 days treatment confirm the diagnosis. Imaging: ultrasound or CT scan, mainly to detect number, site, and size of the abscess. Chest X-ray detect pleural effusion, and pulmonary collapse also reveals elevated right copula of the diaphragm. Treatment, conservative treatment, highly successful. Metronidazole is a drug of choice, 800 milligrams 3 times per day for 7 to 10 days. Ultrasound-guided percutaneous aspiration is needed for abscesses which fail to respond to treatment within 72 hours, and for large abscesses, aspiration is done by large bore spinal needle under local anesthesia. The site of aspiration depends on the site of the abscess. If anterior, insert needle below the costal margin anteriorly. If posterior, insert in the tense intercostal space posteriorly. Few days later, ultrasound is repeated, and if the abscess cavity has recollected or more than 5 cm, aspiration is repeated. Open drainage indications are presence of secondary infection, if the abscess is pointing, and if aspiration is difficult because of multilocular abscess or presence of thick pus. Metronidazole is diagnostic and therapeutic. Although diagnosis is by isolation of the parasite, patients with clinical signs of amoebic abscess will be treated empirically with metronidazole and investigated only if they don't respond. As most of amoebic abscesses are in the posterior superior segment of the right loop, open drainage, which is rarely needed, is done through the bed of the 12th rib posteriorly through extrapleural approach. Hydatid disease of the liver, geographical distribution, prevalent in sheep-rearing parts of the world. In Middle Eastern countries, the disease is commonly seen in Iraq, Yemen, Libya, but also sometimes met within Egypt. Etiology: the causative agent, tapeworm, Echinococcus granulosus. Life cycle: the adult worm lives in the intestine of the dog, the definitive host. Ova are passed into the dogs from the dog's stool and ingested by sheep as they feed on uncontaminated grass. In the sheep's stomach, ova hatch, penetrating the wall and entering the portal venous system to lodge and forming cysts, mostly in the liver, and less frequently in the lungs or brain. Sheep are considered to be the secondary host. The parasite's life cycle is continued when dogs eat liver of dead infected sheep. Man may be accidental secondary hosts through vegetables or hands, which become contaminated with dog's excreta. Pathology: gross picture: the liver may be the site of a single or multiple hydatid cysts. The cyst fluid usually colorless and clear, but may be yellowish if the cyst communicates with bile ducts. Scoliosis are found in this fluid and may cause severe anaphylactic reaction if it gets to the circulation. Microscopic picture: double layer cyst wall, germinal layer, endocyst. The inner thin layer is the living part of the parasite which secretes the hydatid fluid, showing folds forming broad capsules that contain heads of future worms. Scoliosis: daughter cysts may form inside the main cyst. Laminated membrane or ectocyst: the outer layer formed by parasite from the germinal layer, separated from adventitia by plane of cleavage. This plane is lost in liver infections. Adventitia or pericyst formed by the host as a reaction to intrusion of the parasite. Fate and complications: the fate is quite variable. The majority of cysts continue to enlarge gradually. In others, the parasite dies and the cyst is calcified. Complications which endanger the patient's life: small proportion. Secondary infection: rupture of the cyst in the biliary passage causing jaundice, rupture in the peritoneal cavity leading to dissemination and anaphylactic reaction. Clinical picture: may be asymptomatic for years and discovered accidentally with ultrasonography, which is done for another purpose. Usually presentation is chronic right upper quadrant pain and hepatomegaly. Rarely, the disease presents by one of its complications, and in 70% of cases, the cyst is felt as a well-defined, painless, fluctuant swelling. Investigations: lab, blood picture, eosinophilia, intradermal Cassuni's test. The disadvantage: once positive, it remains so for the rest of the life, gives false positive results in 40% of cases. It's now replaced by more sensitive heme agglutination ELISA test or complement fixation test to detect hydatid antibodies in the serum. Imaging: ultrasound or CT scan, showing well-circumscribed cysts. In endemic area, liver cyst is usually caused by hydatid disease. Daughter cysts may be also visualized. In 2001, the WHO classification of hepatic hydatid cyst is used to assess the stage of hepatic hydatid cyst on ultrasound. It's useful for deciding its appropriate management depending on the stage of the cyst. There are 6 classes of hydatid cyst in ultrasound: CL, CE from 1 to 5, and CE5 entails the presence of calcification in the wall of the cyst. Equals: the cyst is inactive and infertile, so no treatment is required. So whenever there is calcification, no treatment is required. Treatment: surgical removal except for small asymptomatic cysts. Preoperative estimation of the number and site of the cysts. The danger with excision is the possibility of hydatid fluid spillage into the peritoneal cavity, risk of peritoneal implantation of the scoliosis forming other cysts, absorption into circulation, life-threatening anaphylactic reaction. So when the liver cyst or cysts is approached, it's surrounded by dark green towels which are moistened with a scolicidal agent such as hypertonic sodium chloride or povidone iodine betadine. The dark green color is suitable background to visualize any spilled scoliosis. The cyst is first aspirated and hypertonic sodium chloride is injected to make it 3/4 full. The overlying liver substance and the surrounding adventitia are incised, and the double-layered cyst is easily inoculated. Small cysts need no further treatment. The cavity left by a large cyst is filled with pedicled omentum. PAIR, P-A-I-R, puncture, aspiration, injection of hypertonic saline, and re-aspiration. This is a recent line of treatment, a substitute or complementary to surgery. The risks are spillage, anaphylactic shock, hemorrhage, or sclerosing cholangitis if the cyst is communicated to the biliary tree. Medical treatment with mebendazole or albendazole, not a good substitute for surgery, but it's used in treatment for elderly patients or recurrent cases. Some advise pre- and post-operative using to prevent recurrence. The usual dose of mebendazole is 400 to 600 mg 3 times per day for 2 weeks pre-operatively and 3 months post-operatively. Liver cysts include the following: simple cyst, polycystic liver disease (PCLD), abscesses, neoplastic cysts. Simple cyst, solitary non-parasitic cyst, which is believed to be congenital. Polycystic liver disease, congenital disease, usually associated with autosomal dominant polycystic kidney disease, rarely associated with hepatic fibrosis or liver failure. Then abscesses, then neoplastic cysts, which are either due to central necrosis of liver tumors or true intrahepatic neoplastic cysts, which are rare, cystadenoma or cyst adenocarcinoma. CEA, mucin, and cytology from the cyst fluid are required to differentiate benign from malignant cysts. Treatment is liver resection. Liver cirrhosis. Definition: condition in which the whole liver is replaced by multiple nodules separated from one another by anosmosing sheets of fibrous tissue. Cirrhosis is the end result of the following pathological processes: long continued loss and necrosis of liver cells, persistent inflammatory reaction, regeneration of the liver lobules in an irregular manner with loss of architecture leading to a large number of nodules, place of portal tracts and hepatic veins are irregular in the nodules, extensive fibrosis, fibrosis and architectural distortion, interference with the blood flow, continuous loss of liver cells, even in the absence of the original insult which caused the cirrhosis. Etiology: post-viral, alcoholism, biliary cirrhosis, congenital, nutritional, cryptogenic, and cardiac. Post-viral, now the most common cause of cirrhosis in Egypt. It can occur in association with bilharzial periportal fibrosis. 10% of patients who get virus B and 50% of patients who get virus C hepatitis not recover completely and develop chronic active hepatitis. There's piecemeal necrosis of the liver, destruction of the liver cells at the interface between connective tissue and parenchymal cells. Lymphocytes or plasma cells infiltrate between liver cells, leading to cirrhosis of macronodular type. This type occurs at younger age than alcoholic cirrhosis. Its clinical progress is rapid, and there's also higher incidence of liver cell carcinoma. Alcoholism, common cause especially in Western countries, high and continuous consumption. Hepatotoxic level is a daily dose of 100 grams of alcohol. Alcohol alone produces cirrhosis, but associated nutritional deficiency aggravate its toxicity. Chronic alcoholism lead to fatty liver, and third of them will progress to alcoholic hepatitis. Third of them complicate with cirrhosis. More in males, usually between 40 to 70 years of age. Usually in the early stages is micronodular type, but later it shows the mixed or macronodular varieties, progresses more slowly than most other types. Abstinence of alcohol intake may lead to improvement. Biliary cirrhosis, secondary to long continued cholestasis due to harmful effect of retained bile on the hepatocytes. There are two types, primary and secondary. Primary biliary cirrhosis is of unknown etiology. There is lymphocytic and plasma cell infiltration of the small intrahepatic bile ducts, leading to fibrosis of the portal tracts and cholestasis. Irregular loss of liver cells and nodular regeneration complete the picture of cirrhosis. Supposed to be due to an immune reaction, can be diagnosed by detecting antimitochondrial antibodies and by liver biopsy. Secondary biliary cirrhosis due to prolonged mechanical obstruction of the large biliary passages, as in congenital biliary atresia, sclerosing cholangitis, or post-operative biliary stricture. Biliary obstruction leads to accumulation of bile in the hepatocytes, bile canaliculi, and Kupffer cells. A progressive inflammatory reaction develops in the portal tracts, followed by fibrous septa linking up adjacent portal tracts. Congenital cirrhosis secondary to a group of metabolic abnormalities and include Wilson's disease, hemochromatosis, Wilson's disease or hepatolenticular degeneration, is autosomal recessive disease in which increasing amounts of copper accumulate and damage the liver, the kidneys, and lenticular nuclei with the eyes. The end result will be liver cirrhosis, Kaiser-Fleischer rings, and cornea and muscular tremors with spasticity. Hemochromatosis, excess deposits of iron in hepatocytes, Kupffer cells, and portal tract macrophages. Increased amounts of lipofuscin are also present in hepatocytes. Excess iron stimulate fibrous tissue formation leading to cirrhosis. Excess iron deposits occur also in pancreas leading to diabetes. And alpha antitrypsin deficiency with galactosemia. Nutritional cirrhosis, protein deficiency can lead to cirrhosis. The liver in these patients is susceptible to some toxic agents which don't affect the normal liver. Cryptogenic cirrhosis, no definitive cause. Cardiac cirrhosis is due to Budd-Chiari, veno-occlusive, and long-standing right-sided heart failure. Cirrhosis entails necrosis, regeneration, and fibrosis. It was previously thought to be an irreversible disease. Now it appears that, with treatment of the underlying insult, whether alcohol or chronic hepatitis C or hemochromatosis, can lead to some reversal of the fibrosis. Bilharzial periportal fibrosis. This is not true cirrhosis. Large number of ova laid in the terminal radicals of the mesenteric vessels fall to engage in the walls of the vessels and form emboli in the portal bud. The ova reach intrahepatic radicals of the portal vein and escape in the portal tracts, producing bilharzial granuloma, fibrosis, and excess fibrosis of the portal tracts, simulating cirrhosis. As the criteria of cirrhosis are not present, bilharzial fibrosis is not considered as true cirrhosis. Pathology, gross appearance. In the early stages, the liver may be of a normal size, enlarged if there is fatty infiltration of liver cells or hyperplastic regenerating nodules. As the disease progresses, the liver shrinks due to loss of liver cells and extensive fibrosis. The surface is nodular. The cut surface reveals whole liver replaced by rounded nodules separated by fibrous tissue. Cirrhosis is classified according to the gross appearance into micronodular type. The nodules are of the same size, but about 3 mm in diameter. Macronodular type, the nodules are of variable size, up to 1 cm in diameter, and the final is mixed type. Microscopic appearance, nodules show loss of the normal architecture. Portal tracts and hepatic veins lost their regular spacing. There are foci of liver cell atrophy and foci of hyperplasia and hypertrophy, so that the cells are enlarged and include binucleate forms. There is extensive fibrous tissue, septa, between the nodules composed of fine or dense collagen fibers. The portal tracts and hepatic veins are included in fibrous tissue. Lymphocytes and plasma cells infiltrate the connective tissue, and less commonly the parenchymal nodules. Gross and microscopic appearances of bilharzial periportal fibrosis is classified into two types, depending on the type of portal tracts involved. This means fine bilharzial periportal fibrosis and coarse bilharzial periportal fibrosis. Fine bilharzial periportal fibrosis, few ova are deposited in the small portal tracts. The external surface of the liver is nodular, each measure up to 15 mm in diameter, and are separated from each other by depressions in which the capsule is opaque, second by fibrous tissue. Microscopic examination reveals strands of fibrous tissue enclosing partially or completely one or more of the liver lobules. Few bilharzial ova may be within the fibrous tissue. Coarse bilharzial periportal fibrosis, large number of ova deposited in the large portal tracts. Gross fibrous thickening of the affected tracts occur. The liver is often reduced in size, and the surface shows multiple shallow depressions separating slightly raised areas. The cut surface showing characteristic second large portal tract, and this is something called pipe stem cirrhosis. Microscopy may show bilharzial worms in the portal veins. There is no gross damage to the liver lobules in bilharzial fibrosis. Only some pressure atrophy of the liver lobules may occur in the neighborhood of the thick portal tracts. Sequel of bilharzial periportal fibrosis is obstruction of the portal vein radicals in the portal tracts leading to pre-sinusoidal obstruction. which is pre-sinusoidal portal hypertension. Clinical sequelae, the patient will suffer from two major problems: hepatocellular insufficiency and portal hypertension. Portal hypertension due to interference with portal blood flow. Hepatocellular insufficiency due to diminution of functional capacity of the liver. Cirrhosis may remain silent for some time and discovered only after routine liver function tests or ultrasound. In some patients, the functional reserve of the liver is adequate to make them look fine, but an insult to the liver, as in GIT hemorrhage, using narcotic drugs, bacterial infection, and anesthesia, leading to severe parenchymatous damage. Cirrhotic patients will usually elicit one or more of the following: spider nevi. These are located in the face, neck, upper arms, and each consists of central arteriole, which irradiates some small vessels. Anorexia with loss of weight and ill health. Palmar erythema. The hands are warm, the thenar, hypothenar eminences are bright red. Testicular atrophy and gynecomastia occurring in males due to failure of the liver to inactivate estrogens. In females, there may be menstrual irregularities, breast atrophy, or secondary amenorrhea. The mechanism is unknown. Bleeding tendency leading to epistaxis, bleeding gums, easy to form hematoma. There is disturbance in synthesis of all coagulation factors except for factor VIII, in addition to thrombocytopenia due to portal hypertension or hypersplenism. Hyperdynamic circulation with warm hands and increased cardiac output due to hypervolemia and vasoactive substances. Jaundice. Mild or moderate jaundice is present in late cases of cirrhosis. It's a bad prognostic sign. Ascites, multifactorial. Hypoalbuminemia is the first cause because the liver is the only site of albumin synthesis. When albumin level drops below 3 grams per 100 milliliters, it leads to ascites. Portal hypertension alone cannot cause ascites. Salt and water retention due to high levels of aldosterone, estrogens, and antidiuretic hormone. Increased lymphatic exudation from the surface of the liver due to lymphatic obstruction, and those are the causes of ascites. Hepatic encephalopathy, representing combination of neurological symptoms and signs accompanying advanced decompensated liver disease and or extensive portal systemic shunting. The exact etiology is not known. The patient develops apathy, lack of awareness, lethargy, disorientation, maybe coarse-flapping tremors, and muscular rigidity. The condition may progress to deep somnolence and finally coma. Common associations: chronic duodenal ulcer, chronic pancreatitis, enlargement of parotid glands, debuterans contracture, primary liver carcinoma, hepatocellular carcinoma developing in 10% of cirrhotics. Suggested causes of hepatic encephalopathy are high levels of ammonia, false neurotransmitter as octapamine and mercaptan, other amines in the blood and cerebrospinal fluid, defective ratio between branched chains and aromatic amino acids. Treatment: unfortunately, established cirrhosis is an irreversible pathology. Complete abstinence from alcohol. Avoid intake of any drugs or anesthetics that are hepatotoxic. High carbohydrate intake and vitamins to support the liver. The only curative treatment is liver transplantation. Studies of the liver. Laboratory tests, liver function tests. They are divided into tests which assess synthetic functions of the liver, or excretory functions, or denoting liver cell injury, and finally serum bilirubin, total and direct, is a test of the synthetic and excretory functions. Total bilirubin normally from 0.3 to 1 mg per milliliter, 100 milliliters. Direct bilirubin from 0.35 per 100 milliliter. Tests which denote liver cell injury are serum aspirate aminotransferase and serum alanine aminotransferase, AST and ALT, and they are normally from 5 to 40 international unit per liter. Tests which assess excretory functions of the liver are alkaline phosphatase, normally from 30 to 110 international unit per liter, 5-nucleotidase, and gamma-glutamyl transferase from 10 to 50 international unit per liter. Tests which assess synthetic functions of the liver: serum albumin from 35 to 50 grams per liter, prothrombin time 10 to 15 seconds, partial thromboplastin time from 35 to 40 seconds. Tests for viral markers: hepatitis A, B, C, D, E. Tumor markers: alpha-fetoprotein and CEA. Alkaline phosphatase may be raised in bony or intestinal problems. Imaging of the liver: ultrasonography, triphasic CT and dynamic, MRI, arteriography, isotope scanning of the liver, and finally liver biopsy. Ultrasonography is the first choice imaging investigation of the liver because it's simple, non-invasive, reliable, not expensive, and easily repeated. It's particularly useful for detecting focal lesions and allowing for guided biopsy. Triphasic CT and dynamic MRI visualize the parenchyma and adjacent tissues clearly. Arteriography is now losing popularity in favor of previously mentioned non-invasive techniques, useful in diagnosis and management of liver tumors. Isotope scanning of the liver was previously common in detecting space-occupying lesions, and it has been nearly replaced by ultrasonography or CT scan. Liver biopsy techniques: the percutaneous technique, laparoscopic biopsy, and liver biopsy at laparotomy. The percutaneous technique, which is the standard method to reduce bleeding, the prothrombin time shouldn't be prolonged more than 3 seconds above the control value. The platelet count should be more than 80,000 per microliter. Even so, it's safer to cross-match 2 units of blood to be ready in case of bleeding. And the procedure is done under local anesthesia through the right mid-axillary line, just below the upper limit of the liver dullness. The commonly used needles are the aspiration, Mengini, and cutting TrueCut needles. To biopsy a focal lesion, passage of the needle is guided by ultrasound or CT scan. Liver biopsy indications: target biopsy of focal lesions which are suspected to be primary or secondary tumors, sometimes indicated. Liver transplant assessment: pre-operative histological diagnosis is essential, and the technique can also help in the early detection of post-operative transplant rejection. Contraindications: bleeding diaphysis, hemangiomas, and hydatid tests shouldn't be biopsied. And this concludes liver part 1.